Hey everybody, my name is Haley, and I am talking about the vulnerable population that has to do with hospice and end of life care. But before I jump in, I do want to apologize that I do not have a Microsoft Office because I have a Chromebook. So you get to watch me do this online awkwardly and record through my internet. So it's going to be not quite the normal presentation. So I apologize about that. So the reason why I chose specifically end of life care is because it's specifically targeting the elderly and the terminally ill, those who do not have long to live. And so specifically with hospice, you join hospice when you have a diagnosis that tells you you have at least or no more than 6 months to live. And sort of that's when they encourage you to consider using the program of hospice. So what is hospice? Hospice is different than palliative care, and a lot of people confuse the two because they're very similar. Palliative care actually is something that can be used and quite often is used in hospitals for people who have any diagnosis, medical diagnosis of any sort, and need treatment with it. So palliative care can be for somebody who's not at end of life. Hospice care starts after the treatment is stopped. So in other words, there's no more medical reason for us to continue treatment because there is no possible diagnosis except end of life. It's clear that the client is probably not going to survive. I can't say that they don't because I do actually know of people who have come off of hospice and actually are doing fine. So hospice itself is a philosophy of care that's directed toward the terminally ill with the purpose of tending specifically physical, emotional, and spiritual needs as they transition to end of life. So the purpose is for the dignity and comfort, and they experience it at their own terms, which is something that in cultural competence we want to be very, very clear on. What is their choices? What do they want to have as their experience of end of life? So I found some information in terms of those who are the heaviest users of Medicaid beneficiaries of chronic conditions. It will be the senior population. And this particular doctor who works for hospice say patients often suffer through unnecessary, costly, and even harmful treatments despite expert opinion that they have a terminal illness. And so many times the medical field tries to force them into more treatment when perhaps more treatment is not what they need. And maybe they need to be focusing on what is more intentional about their life at that point, perhaps, spending time with family, those sorts of things. So I found a particular case that a nurse had shared in her critical care in an ER where a man came in, a Native American man. He was had 2 infarctions in the past, and he was having another. So he told the ER staff, he clearly told them that he wanted to follow his cultural ways of dying. He had made peace with God and he was ready to die and he wanted his family with him. However, this particular physician transferred this man to an ICU, an intensive care unit, 3 hours away. Unfortunately, this patient died 2 weeks later with 2 code blues, as in his heart stopped twice in that. He was intubated, which means they shove a tube down your throat to make you breathe. And he was on mechanical ventilation. They were breathing for him. So no family members were present because while he died, except his wife, because he was so far away, they could not afford it. That is exactly what we do not want to happen, especially when we want to be social workers that are culturally competent. And that is also something that hospice is very clear that they do not want to happen. We want to honor and respect those decisions that they make and how they want to transition to end of life. So I interviewed a woman named Becky. She is a social worker at our local hospice. I live in Central Ohio, specifically Knox County. And she has been in hospice care as a social worker for about 10 years. And she said she worked in mental health before that. And this is her dream job, working with the elderly and the terminally ill and having them transition. And also helping, she said there's a lot that we don't talk about where it's the family members that you actually work with, almost more than the patients, because many of the patients are actually already incompetent to make decisions. They're at the point where they are not conscious sometimes, or they're in too much pain, et cetera, et cetera, et cetera. And so she said that hospice social workers don't function as much as peer support. she felt that in her position, she was more as accountability to the client and the client's family choices. So she made sure she was an advocate for what they wanted. In terms of engagement, social workers are to start the end of life discussions. This is a pretty tricky thing to do. And also talk about expectations, especially before the patient is incapable of actually making those decisions. So our purpose is to listen compassionately to what they're saying, but also what they're not saying. It's hard for us to talk about end of life choices. They can vary in their willingness to, or even readiness to talk about these kinds of things. It's intense. So we offer as much as they would like. We offer as little or as much information as they're desiring and honor those boundaries as they create them. So we need to function in very deep sensitivity, but clear and direct, be able to concisely share what needs to be shared. Assessment. So this is the part where we gauge the client and family's understanding of the services and spend the time to make every resource that hospice offers clear. So much of what that entails, as Becky told me, was it dispels myths. A lot of people think if you start hospice, that you're pretty much going to die within a couple of days or weeks. That's not necessarily true. And also, there's a lot of people that also think hospice means there's no hope for improvement, which is also incorrect. Like I said before, I do know of people, and more than one, who has actually improved to the point that they're no longer on hospice. Part of the assessment also has to do with gathering a life story and the background. So that helps create that cultural picture of this particular family and client. And then it evaluates if the client is being properly served with appropriate. So I don't want to give a man who has a Muslim background a pastor to come in as their chaplain. Like, that's not appropriate. So assessing the caregiver's ability to provide care and not reach burnout. This is also something that needs to be assessed very clearly because caregiving is intense. Empowering the client and family to make good decisions in their unique situation. Everybody cannot be treated the same. In terms of intervention, the client and the family are completely and utterly the ones making the choices. Hospice will be involved as little or as much as they choose. So everybody on the team, medical and social workers, are there for consultation, but we do not make the decisions. So all the details that are hammered out are visits, how often, who goes, who shows up, do they come into us, is there bereavement counseling, et cetera, et cetera, et cetera. So evaluation is evaluate the effectiveness of care and improve the standards of care as needed. So make sure they're getting what they need. Determine the level of readiness for each client and discuss with that family what happens if the client chooses to stay or go in hospice and sort of the fallout of that. And reiterating again what hospice services do and do not do. So one thing that Becky and I sort of discussed in this whole process of this interview was the American perception of death. And we can struggle so deeply about talking even about it. And especially if a family member is been terminally diagnosed, that can be so emotionally wrought. We as a culture are used to being able to pay money or to fight against something to overcome it. But unfortunately, a terminal diagnosis cannot be helped by either. And so this can really emotionally wreck somebody. Becky noted that she sees a radical difference between those who are emotionally and spiritually ready to die versus those who are not. So the implications for social work are this. Terminally ill clients are emotionally susceptible, medically fragile, and overwhelmed. They are suddenly required to make weighty and life-altering decisions. Some clients are incompetent to make decisions on their own behalf or loved ones and might put pressure on the client. Social workers must maneuver all of this with a sensitivity and respect. We are positioned between the medical team and the client and advocate for both as needed. So obviously there's a common theme of social workers sort of straddling that line of helping advocate and equip and resource clients and family members at end of life, but also giving them the time and space to emotionally process and having those cultural backgrounds to respect.